to T3. This particular adjustment is called the modified cross bilateral. Now, I just want to move this way. Okay. I'm just going to ask somebody to assist me with this demonstration. Okay, Jasmine, come on over. I'm going to have you lying prone just for a sec. Now, the modified cross bilateral looks precisely like the cross bilateral with a few twists. The reason we need twists in the upper thoracic spine is because there comes a point where, sorry, my hands are freezing, ice cold. If I were to adjust up here as a cross bilateral, eventually what happens is on the thrust, see how the head kind of moves in extension? And I'm not even thrusting properly, right? The head moves in extension, and if I were actually thrusting properly, I could actually trigger whiplash. And that's not the intention of this whole thing. The intention is not to hurt. So what we need to do is we need to modify the cross bilateral so that we can keep the head stable. Keep the head and neck stable so that we just adjust this point and this point only. Okay. So just to remind you of the motion palpation that would lead you to this particular adjustment, I'm going to need you to sit up and face this way. Cross your arms for me. Okay, and of course to remind you that when you're doing the motion palpation of anybody, you would be starting on one side at the top, working your way all the way down, and then on the other side, working your way all the way down, computing what needs to be done, setting up your treatment plan, and away we rock. But for the purpose of this, I'm going to focus my attention specifically from here to here. Okay? So, to assess for rotation in the upper thoracic spine, you put your finger or your thumb on the spinous process on the ipsilateral side to which you are standing. You're going to get in close. You're going to rotate your patient into you. Now, as you rotate your patient into you, the spinous process should rotate anteriorly, and that's why you should feel a lessening of pressure underneath your fingers as you rotate. There might come a point, though, where instead of the spinous process rotating away from you and you feeling a lessening of pressure, instead it comes into your finger, and that's precisely what's happening here at T3. So, if we've got a spinous process that has rotated to the right, it is a process right, a PR listing, which TVP is most posterior? The left. So it would be the TVP right up here, which is about 1 to 1.5 interspaces above and about an inch and a half lateral too. Right? It's not on the same line.
Remember, but yeah, okay.
1, 2, 3. Here's where I'm feeling. Here's where the spine, where the TVP is. So it's higher up, right? So I wouldn't be adjusting here. That's the wrong segment. I'd be adjusting here, higher up, right? Now, okay, so in you it was a PR listing. I'd have to adjust the other side, but that would block everybody. So I'm going to have to adjust on this side. Okay, let's assume that for the sake of argument, I palpated this guy, and at T2, I've got a PL listing. So do you see this? Do you guys all see what I've done? You can't. Or can you? Come over here. It's PL at T2. See that? It's PL at T2. So the right TVP is most posterior. So I'm going to set this up like a cross bilateral. My pisiform is going to go down onto the TVP that is most posterior, and I'm going to take out the skin slack just like I did with all the rest. I'm going to be using this as the teeter-totter to bring everything to center. Make sense? Okay. But down you go. Let's see if there's anything that's on the other side. So, Jasmine had a PR listing, so I'd have to stand on the left, but then I will block. I can do this. You want to come over? Tell me if I block you guys. You might want to hang out over here. I can do this. Okay, so it was at T3. T3 was PR, so it's the TVP on the left. That is the issue. Let's see where it is. It is right here. Okay, right where I thought it would be. I need to take out the skin slack. Skin slack is taken out either by, with your finger, you hover over it. This looks exactly like a cross bilateral so far, right? Hover over it with your adjusting hand. With your non-adjusting hand, you slide the skin cephalad, and apply your piezoform right to it. Straighten out your arm. Or you could start with your hand rotated laterally. Straighten out your arm, apply a P to A pressure, turn your hand until the hand is facing superior oblique. Or do whatever combination you feel is warranted in order to make sure that you're on. Now, the higher you up in the you are in the thoracic spine, the more likely it's going to be that when you straighten your arm, you're going to feel like you're going to slip off the shoulder. Okay, so you might need to move your body mechanics a little bit so that you feel anchored. What I usually do is I usually have my foot, the foot that is bent in my fencer stance by my patient's ear, and I lean a little bit anteriorly to start. That way my arm feels more secure, because if I'm back here, I'm in line to slip off. So I'm going to just anchor myself by sliding forward a little bit. Okay? My sternum is not over my contact site yet. I'm just anchoring myself. Okay. Now, in a cross bilateral, I would cross over like this, have her take a deep breath in, breath out, and get my sternum over and thrust. In the modified cross bilateral, I'm going to take my non-adjusting hand, and I'm going to take the web of my hand. Sorry, I need your hair out of the way. So let's do this. I'm going to do this. It's okay, I got you. It's okay, I got you. Just need to see this. The web of my hand is going to contact her occiput. And it's going to contact her occiput in such a way that the web between my index finger and thumb is sort of midway between the ear and the midline of the occiput here. And I'm going to be stabilizing her head by tractioning and turning it eventually. That's what I'm going to be doing. Okay, so contact. And eventually I'm going to traction and turn, but right now I'm just hanging out here with my hand on the occipital rim. You could do this. You could do this, but the head is going to be turned and twisted. Which way does it go? What if it's your turn to do this now, and shoot, now I'm watching you and you don't know which way, I don't know. Well, first thing is first, you've got your contact hand down. This hand, if it slides in this way, the only way that it's going to turn, which feels comfy, is that way, because it's not going to feel comfy going that way. Okay? The other thing is that when you turn, the nose is going to be pointing in the direction that the spinous process is going to be going as you do this adjustment. So right now, so here's my spinous process, and this is what's happened. Here are my TVPs. I'm going to be applying a contact to move the spinous process like that. The spinous process is going to be going this way, and guess what? The nose is pointing in the same direction. But blah, blah, blah. It doesn't feel comfortable going like this. It feels more comfortable going like this. Easy. Okay? Where are we? Here. Okay. Now, Jasmine's going to take a breath in and breath out, and then you're going to breathe normally. So on the breath out, you are going to pivot your body so that your sternum is over your contact site, and then we're going to lean into it, just like we did in the cross bilateral. So this arm's doing cross bilateral. This hand is going to be tractioning and turning and stabilizing the head. Okay? Now, you're going to sink down on that TVP until you feel like it can't move anymore. That's joint slack removal. Once it doesn't move anymore, you are going to do the same thrust that you did with a cross bilateral. This hand is totally stable. It doesn't move. The thrust is the ooh of the spider, followed by or together with the bow of the body and the drop down of the arm. So ooh, 2, 3. It looks like a one-handed CPR. Okay, that's the thrust. Do not thrust with this hand. Do not thrust with this hand. Okay, let's see how this looks. Okay, breath in. All the way out. Wait till she totally exhales. Okay, like that. All right, you okay?